All right. Greetings, everyone. Welcome to our webinar, Africa Confronting COVID-19. This webinar is co-hosted by Columbia Global Centers Nairobi, Columbia Global Centers Tunis, and ICAP at Columbia University in New York. My name is Murugi Dirango, and I'm the director of Columbia Global Centers Nairobi. All the Columbia Global Centers, we have 9 centers around the world, connect their various regions to Columbia University to facilitate research and scholarship. Let me now invite my colleague, Youssef Sharif, to say a few words.
Thank you, Murugi. Welcome, everyone. Welcome again. This time we're on again, and we have so many participants. So we're looking forward for this great webinar. I'm Youssef Sharif, the head of Columbia Global Center Tunis. We're working on North and West Africa, and with the Global Center in Nairobi. We're also trying to work as much as possible with on African issues. And we're very happy with this partnership with ICAP at Columbia and also with the Tunisian Center for Public Health in Tunisia. Thank you. And now I pass the floor to Wafa Sadr.
Good morning, good afternoon, and good evening, everyone. I'm Wafa El Sadr. I'm the Global Director for ICAP at Columbia University, and similarly very honored to co-sponsor this webinar with colleagues at the Global Centers in Nairobi and Tunis. I'm going to start with a few introductory slides and then go on to our speakers. Next slide. Just a few housekeeping issues. Most importantly, please keep your video off to facilitate better transmission, and chat is possible only to the host, and attendees cannot unmute, so please enter your questions into the chat box to the host. Next slide. So today I'm going to give some, first you heard the introductions from Murugi and from Youssef, and I'll give a very brief presentation with a global update on COVID-19. Next slide, please. So just to give you a brief update on where we're at today, as of yesterday, April 22nd, there were more than 2.5 million confirmed cases of COVID-19 globally. And I stress the word confirmed because we believe and we know that there are many more cases than the confirmed cases. Confirmed cases are those where an individual has had an actual test that was confirmed that they were positive. We probably believe that at least twice, if not 3 times, or even more, 5 times as many cases exist globally. As you can see, there have been more than 171,000 reported deaths, but also many thousands, hundreds of thousands of recoveries. And obviously the numbers of recoveries lags behind, as many of the cases have been reported recently. Now, the impact of this pandemic varies substantially by region, and as you can see, 50% of global cases currently have been reported from European countries, or about 1/3 of the global cases have been reported from the US. 3% of the global cases have been reported from China, and at present, less than 1% of confirmed cases have been reported from Africa. At the bottom of this figure, the map on your right, you can see that the top countries in terms of the largest numbers of reported cases now are the US, Spain, Italy, France, and Germany. Next slide. I can do that. Next slide. So the evolution of this pandemic is important to note. And in this figure, you can see that early on, by about the end of December, beginning of January, were the beginning of reported confirmed cases here in this light orange. And these were the cases that were reported largely from China and the Western Pacific, and China and South Korea and so on. And then over time, you can see that now the majority of cases are being reported from, in this darker orange, from European countries, and in this yellow color from the Americas. But you can also see as well that in blue here at the bottom, the numbers of cases reported from Africa, as well as from continuing the reporting of small numbers of cases from the Western Pacific. But by far now, the majority of cases are from, you can see here, from Africa and from, from Europe and from the United States. Next slide. Now, to give you a sense about what's happening in the US and New York City, where we are situated, both the Columbia University and the Global Center headquarters, the current snapshot is there are 788,000 more cases, confirmed cases reported in the US. And currently, the US, as I said, is about a third of the global cases have been reported from the US, and 17% of cases have been reported from New York City. New York City is now at the epicenter of the global epidemic with more than 132,000 confirmed cases, which is about more than half of the total numbers of cases in New York State. Actually, the numbers of confirmed cases reported from New York City is currently more than the number of cases from any other country apart from the United States. Next slide, please. Now, what about the situation in Africa? And in the slide, you can see here that there have been more than 23,000 confirmed cases from African countries. However, that still remains, that is about less than 1% of worldwide cases, with 1,160 reported deaths. And important to note that the majority of the cases the majority of African countries have reported cases of COVID-19. And the reason for our webinar today is, of course, there's a great concern in terms of the potential impact of transmission of this virus in African countries in all the regions of Africa. As you can see here, the majority of the cases have been reported from North Africa, and then also substantial numbers of cases, and those have been from Egypt and Algeria and Morocco. Southern Africa, and South Africa has reported the largest number of cases. But also there's a concern about the evolving epidemic in West Africa, with substantial numbers of cases being reported now from countries like Cameroon, Côte d'Ivoire, Ghana, and other countries in West Africa. Next slide, please. So if you look at the global trends per continent, look at North America, for example, you can see here, and the y-axis is 10,000 cases, and the y-axis here, and you can see that in North America, the US is certainly leading in terms of the numbers of new cases and numbers of cases reported. In Europe, there's been the countries I've mentioned already that have been most severely affected have been Italy, Spain, France, and Germany. However, there's also concern now about increasing numbers of cases, for example, in Russia and Belgium, amongst other countries. In Africa, while again, if you look at the y-axis, numbers of cases has remained small, but nonetheless, there's also concern about potential growth in the numbers of cases, and we'll talk about that in the presentations to follow. In Asia, though, there's been a plateau in terms of the numbers of cases that are reported from countries like China, with concern about the rapid increase in numbers of cases in Turkey as one example. Next slide. Now, we all know that epidemics go through phases, and we will hear from the speakers essentially where their countries are in terms, and their regions are in terms of these phases. So if you look at the top here are the epidemic phases, from introduction or emergence to localized transmission, followed by amplification, and then reduced transmission. And at the bottom, you'll see what should be done. What are the response interventions that need to be done? And these interventions need to be tailored to the epidemic phases. So obviously, it's very important to anticipate and be prepared for the potential outbreaks of novel infectious diseases, but also it's critically important to have early detection so that as soon as a virus or a pathogen is identified, it can be early detected as soon as possible, through usually training of clinicians and having astute clinicians in the field who can be alert to identifying unusual cases and also clusters of cases, as well as having laboratories also prepared and surveillance systems in place to be able to detect new pathogens. Then when there's localized transmission, as you can see in this figure here, then containment is the intervention of choice. And by that, we mean identifying the cases rapidly and isolating the cases, as well as identifying their contacts and making sure that all the contacts are quarantined and followed to determine if any of them develop the disease, and then to isolate them and then identify their contacts and so on and so forth. And this is a very important phase that must be intervention that needs to be put in place early on in order to make sure that the transmission remains localized. However, with amplification, for example, of transmission, can you go back one slide, please? Go back. However, with amplification of, no, now forward. Yes, with amplification of transmission, at this point, it's very hard to continue the containment efforts, and that's where control and mitigation efforts need to go into action, largely through what you've all are aware of, limitation of travel, closure of schools and universities, lockdown, stay-at-home measures, and social distancing. And then hopefully, if these are effective, then you can go into a mode of suppression with the reduction in transmission and hopefully aim for elimination or eradication. Next slide. Very briefly, I want to tell you what ICAP is doing in the African context, particularly to support the COVID-19 response. And as you can see here on your left, there are a variety of activities, including the purchasing and support of personal protective equipment, medical equipment, logistics support in several countries, supporting the establishment of COVID-19 treatment centers, supporting technical assistance to several countries in their response, supporting the national COVID-19 surveillance system, and then supporting the establishment of fever clinics, triage centers, and health brigades. Next slide, please. In addition, also, we're embarking on a project that is aiming, an ambitious project, to provide training to 13 countries in the sub-Saharan Africa, listed here on the right, to train district teams as well as frontline workers in terms of the control, prevention, and management of COVID-19. Next slide. So in summary, COVID-19 pandemic continues to grow and evolve. The US is most severely affected country currently. New York City remains in the eye of the storm. Most countries, African countries, have reported cases of COVID-19, and it's critically important to carefully monitor the epidemic in African countries, as well as to put in place the needed vigorous containment and mitigation measures. And we all know and should always keep in mind that epidemics know no borders, and thus what happens in one country is very critical to all other countries, because we are one world, and controlling the epidemic in one country is impossible without controlling it elsewhere around the world. So at this point, next slide, we'll move on to hear from several speakers. And our first speaker will be presenting the perspective of North Africa. And I hope that Dr. Habiba Ben Romdani is with us on the webinar, and she's a former Minister of Health from Tunisia. I think if Dr. Habiba is not with us at this point, we might want to please move the slide to hear from, we're going to hear then from Mark Hawken, who's going to be presenting the perspective from East Africa, to be followed by Blanche Pitt, who will present perspectives from Southern Africa, and then Stefania Koblavi-Deme, who is going to present the perspective from West Africa. Mark, welcome.
Thank you very much, Wafa. Good morning and good afternoon, everybody. Could I have the first slide, please, Hugh? Thank you. In the next 10 minutes, I'm going to try and give you a snapshot of the COVID-19 situation in East Africa. Next slide, please. East Africa, in fact, is defined by the United Nations as 20 territories along the coast of the eastern region of Africa. But in fact, I'm going to limit myself to Kenya, where I am, and to our neighbors, Tanzania, Ethiopia, Uganda, and South Sudan. Next slide, please. Yes, as Wafa has said, and as you well know, the epicenters at the moment are located in Europe and in North America, but we are starting to see a smattering of cases throughout Africa, as you can see on this map. Next slide, please. Yeah, these were the figures yesterday, and 53 of the 55 countries in Africa had reported cases, with confirmed cases of over 23,000 and over 1,000 deaths to date. Next slide, please. Yeah, this line graph just shows the order of the countries in terms of confirmed cases of COVID-19. And you'll see at the moment, Egypt is leading as #1. South Africa last week was #1, but #2 this week. And you'll see Kenya there in 17th place, followed by Tanzania, and the other East African countries that I mentioned. Next slide, please. So I just want to give you a snapshot of what's been happening in Kenya, and it's outlined in this slide. The National Emergency Response Committee was activated earlier in the year, and isolation centers have been established in Nairobi, at Kenyatta National Hospital, at Mbagathi Hospital, and more recently at the Kenyatta University Hospital. And our first case was identified on the 13th of March. This was a 27-year-old lady who had traveled from the US via London. She has since recovered, but 2 of the passengers on the same aircraft were also tested COVID-19 positive. Then this was followed by our first death shortly thereafter. Next slide, please. These are the figures as of yesterday for Kenya. Kenya has tested over 13,000 people and confirmed 281 cases with 14 deaths. Next slide, please. Yes, this just shows the progression of the epidemic in Kenya over the last month or so. Next slide, please. The actual increasing nature of the epidemic is perhaps shown better in this slide. Next slide, please. And here you'll see that most of the cases have been centered around urban areas, the metropolitan area of Nairobi, and also at the coast, particularly the city of Mombasa. But you'll see that with this is relatively early, and with time it's been spreading out, and cases have now been reported in Western Kenya as well. Next slide, please. Yeah, the government response has been particularly strong, both from the President and from the Ministry of Health. Next slide, please. The next slide here just outlines some of the mitigation measures that have happened in Kenya. So I'll just take you briefly through those. We started with school closure and a public gathering ban. I'm just taking you through from below the timeline, the blue dots. That was followed by our first case in early March, the 10th of March or so, followed by aggressive contact tracing and quarantine of incoming passengers. Air borders were then closed to non-residents, to non-citizens, and then following that, religious gatherings were banned. Visits to prisons have also been banned, and then eventually all entry by air and road were closed. Following that, we had, with increasing numbers of cases, a night curfew imposed. And then more recently, has been really an order for the wearing of masks in public. Again, in response to increasing numbers of cases, particularly in the Nairobi and in the coastal area, we've had a travel restriction to and from the Nairobi County and also to and from 3 of the counties at the coast, Mombasa, Kilifi, and Kwale. Next slide, please. So this just outlines some of the activities that the ministry has put in place in response to the pandemic. I mentioned that the emergency response team has been activated. A contact tracing team was established early on and has been very active. We have at least 6 national laboratories now that have testing capacity. The capacity is currently good and kits are available currently. Multiple quarantine centers have been established in each county, in schools and tertiary institutions, and multiple isolation centers have been set up in each county throughout the country. PPE, personal protective equipment, has been made available through the government and through donations by Jack Ma Foundation and others, and that is being distributed throughout the country. But generally, at the moment, within the counties is quite in limited supply. Sensitization training modules have been developed by the Ministry of Health, and these are currently being delivered to healthcare workers by video conferencing, and SOPs and guidelines have been written and distributed. In addition, the government has announced some social relief in terms of tax relief for people who are earning less than $240 US per month. There's been a reduction in pay as you earn from 30% to 25%, and value-added tax has been reduced from 16% to 14%, which has already been put in effect. Next slide, please. So having given you some idea of what's happening in Kenya, I just wanted to look at very briefly at our neighbors, and similar mitigation activities have been put in place in each of these countries. This just shows the picture in South Sudan. South Sudan only have 4 confirmed cases, all introduced from outside, and no deaths so far. Next slide, please. This is the picture in Ethiopia. They have 111 reported cases as of yesterday, with 3 deaths. The government there has introduced a 5-month national state of emergency, and interestingly have pardoned hundreds of prisoners in an attempt to reduce transmission within the prisons. Next slide, please. This is the picture for Uganda with 55 reported cases and no deaths so far. The government response in Uganda has been particularly, they've taken it particularly seriously and put in severe measures. Most of the ones that I've mentioned for Kenya and the other countries are in place. But in addition, they had put in restriction of, well, suspension of public transport and also private transport. And they've shut down all malls and shopping centers. The only shops that are open are food shops. Next slide, please. This shows the picture in Tanzania. Yesterday they had reported 255 cases and 10 deaths. So sort of a similar picture to Kenya. A week ago, they actually only had about 55 cases. So they've really increased their cases over the last week. The first case was a 46-year-old Tanzanian man who had come from Belgium in March. So as I said, similar mitigation measures have been put in place, but Tanzania had not made it compulsory for bars, restaurants, shops, or churches to close. Next slide, please. This just compares the first 30-day trajectory, the number of cases reported in Kenya, as you'll see there in the lead, with the other 4 countries that I've been talking about. So you'll see a much steeper increase over the first 1 month from Kenya. Next slide, please. The next one just shows Kenya compared to South Africa. I thought that was an interesting comparison with much steeper increase in numbers reported in South Africa compared to Kenya. Next slide, please. I just wanted to turn now at this stage to talk about the support that ICAP has put in place. We're currently supporting a teaching and referral hospital in Kisumu, and there we've assisted them with establishing outside triage areas. We've designed and printed SOPs and algorithms. We've helped them design and print M&E tools and registers to keep track of the number of cases, number of admissions and discharges. We've provided PPE and sanitizer. And currently we're equipping an isolation unit in preparation for a presumed surge with a kind donation from a Dr. Zhao, who is a member of the Columbia Board of Visitors, who has kindly donated money towards this cause. Next slide, please. I just wanted to pause to think just about vulnerable populations, particularly in Africa, street children that don't have a home to stay in, persons with psychiatric illness, and here I'm talking about those with severe psychiatric illness in hospital where it may be difficult to practice social distancing and the other measures, persons who inject drugs, and those on methadone programs, those in elderly care homes who have much increased risk of severe disease, and those living below the poverty line. Next slide, please. So in summary, Kenya and neighboring countries are at a relatively early stage of the pandemic. However, community transmission is occurring. Mitigation measures have been put in place within the context of political and socioeconomic environment. But mitigation measures are severely impacted by poverty and by high density informal housing. Test kits, PPE, and specialized care are likely to be in short supply as the pandemic progresses. Thank you very much.
Next slide, please. Okay, welcome, Blanche.
Thank you. Good afternoon, everyone. And we can move to the next slide, please. The next slide, please. Thank you. So my presentation will briefly cover the status of the COVID pandemic in Southern Africa. I will then proceed with a deeper dive into South Africa and the country's response to the pandemic. Next slide, please. This slide gives a snapshot of the exponential increase of COVID-19 across Southern African countries. And I'll be referring to the 9 Southern African countries highlighted on the map on the left of my screen for the period the 5th of March to the 19th of April. So from the time of the first reported case, we see a continuous upward trajectory for Southern Africa. And you can see the line graph on the right. Over just a period of 4 weeks, the virus has infected almost 4,000 people across Southern Africa. And as Wafa said earlier, these numbers account only for the recorded and confirmed cases of COVID-19. The actual number could be much higher. So without significantly increasing testing coverage, the data will continue to reflect only the people who themselves report for testing and their contacts. And this really highlights the need for expanding our testing coverage. Next slide, please. Here you can see the increase in the first wave of the COVID-19 in South Africa compared with the total number of combined COVID cases in Southern Africa. Of concern is, of course, the high prevalence of immunosuppressive conditions, including HIV and other comorbidities, which increases susceptibility to COVID infections. South Africa remains the epicenter of the COVID pandemic in Southern Africa, as well as the country with the largest AIDS epidemic globally. And this really highlights that while we are intensifying our mitigation measures for COVID-19, that we need to ensure that HIV, TB clients and other clients with comorbidities have access to and remain on treatment. Otherwise, we would again see quite a rapid increase of those more susceptible. Next slide, please. While during the first wave of the pandemic, the number of COVID confirmed cases in Southern Africa has been relatively low so far compared to other countries in the West. We are starting to see a steady increase, as you can see on the slide, across all countries, except Lesotho, who has to date not confirmed cases. If you look at Zambia, that's the second highest number, with 61 confirmed cases within 1 month of its first case, followed by Mozambique with 39 confirmed cases within 4 weeks, and Zimbabwe with 25 as of the 19th of April. This shows us the rate to which the pandemic is rapidly spreading across Southern Africa. And we really have very limited time to change the course of this epidemic. From the lessons learned, we recognize that it is critical that countries prioritize testing to identify those infected early and put in place good systems for contact tracing and isolation, as well as other mitigation measures we've seen have made an impact, like lockdown, social distancing. From the South African experience, we have seen that internal transmission has a tendency to spread rapidly and silently. So we can't afford to be complacent. There has been much concern about the existing capacity, of course, with regard to the hospitals across Africa, capacity of ICUs, of health workers, supply chain capability, as well as good surveillance systems. A positive step, though, is the remarkable collaboration that we have seen with joint planning and sharing of lessons and resources among African countries, which has been facilitated by various bodies, including AU, WHO, and CDC. And so we are really very serious about learning from, what has worked, both in Europe and in America, but also, of course, across Africa. Next slide, please. In terms of date of reporting the COVID cases, South Africa was the first country to report the COVID case, followed by Eswatini and Namibia 9 days later. All Southern African countries went into lockdown soon after the very first confirmed case of COVID-19, with a mean of about 8.7 days from the time of the first reported case to lockdown. And as we have learned from the lessons from the other countries, of course, early lockdown and social distancing has been shown to be two of the most effective mitigating measures for COVID-19. And so it's really encouraging to see that countries in Southern Africa have since implemented a range of additional measures to slow down the spread of COVID-19. What we have learned is that the importance of each country developing strategic plans to deal with the epidemic. You will notice I have a question mark next to Malawi, and you may all be aware that the president was challenged by the court on introducing lockdown. And so we're really hoping that that matter will soon be resolved. Next slide. In South Africa, so this slide shows the upward trend that we have seen in South Africa. So I'll start just focusing on South Africa for now. And here we can see there's been an exponential increase of COVID-19 over the period starting the 5th of March, April 19th. And the significance of the impact of the lockdown is evident. If you can look at the screen and perhaps look at the 27th of March, that's when we had our lockdown. And what we saw from the 27th is we did not see that spiraling increase that we observed during the prior period, starting from the 5th of March. And so lockdown has really made a significant impact. We have, after that, seen a continued increase as the country rolled out its nationwide screening and testing. And as of the 19th of April, we had 3,158 cases confirmed. Next slide, please. I'd like to pause a bit on this slide because it really also shows not only the trajectory of the epidemic in South Africa, but what's significant about the slide is, you know, if one looks at where we start on the 5th of March until the 13th of March, that was the period where the transmission was external. So the infected cases were coming from countries, high burden COVID countries. Our first internal transmission cases, confirmed internal transmission cases, happened on the 13th of March. And so from the 13th of March, of course, you know, going forward, we can see that there's a gradual increase and then quite a significant increase on the 27th of March, where the country reported 243 cases for that specific day. And that's been one of the highest number of cases per day that we have seen. So if you can look at the bottom of the screen again on the dates, where you can see the 27th of March and 28th of March. So South Africa went into lockdown on the 27th of March. And we notice a remarkable downward trend thereafter. It's very significant. So while many factors influence the trajectory, the positive impact of lockdown, as we've seen in other countries, also had a significant impact on the downward trend that we see on this slide. So the days that followed again showed an upward trend. And then on the 11th, we see a dip. The 11th just also happens to be a day on which the majority of South Africans celebrate Easter Sunday. So following lockdown, the country swiftly moved into emergency preparedness, and from the 28th of March, started with nationwide symptom screening, using mobile technology to intensify contact tracing and introduced more accessible testing through mobile labs. The more we expanded our testing and improvements in contact tracing, the more COVID cases we were finding. And you can see, if you again look at the graph, how towards the 18th of April, we saw a significant upward trend again. Next slide, please. So the total number of confirmed cases as of April 18 was 3,158, as I've said, with Gauteng, the economic hub of South Africa, the worst affected. And at the time, they had 1,148 cases, followed by the Western Cape with 868 cases, and KZN with 617 confirmed cases. So the total number of COVID deaths for the country at the time stood at 54, with KZN, KwaZulu-Natal, reporting the highest number of deaths. What we have observed with the deaths in South Africa is that these deaths have not only occurred among older people and those with comorbidities, but also amongst the young. And it's, of course, very, very worrying. Okay, next slide, please. Next slide, please. Thank you. So this is an interesting way of illustrating South Africa's response. It was actually Abdul Karim, who many of you may be familiar with, and is also an advisor to the South African president on COVID-19. So Abdul came up with a very systematic way of staging the South African response. And as you look across this diagram, you know, these stages reinforce each other. So it does not mean that when one stage stops, the other starts. Rather, it's a continuation and an expansion of mitigation measures over time. Again, you know, this was presented on the 10th of April, therefore it only shows data up to the end of April. But I'll just quickly go through the stages and what they represent. So the first stage, and that was almost immediately after, in late February, before we had our first case, it was extensive community education. The country assessed and prepared lab and hospital capacity and strengthened our surveillance system. During the second stage, and this happened after the 5th of March, that's after our first confirmed cases, there was increased emphasis on social distancing, on hand washing, closure of schools and borders, small gatherings or prohibiting large gatherings rather. And as I've mentioned earlier, on the 27th, we went into lockdown. The stage 4, which is, we are still, you know, intensifying this community health door-to-door screening, so active case finding rather than waiting on clients to come to the health facility, and referral of those with symptoms for testing. Stage 4 also started with triaging, so putting up tents outside the hospitals to triage clients. One of the areas that is really guiding us so that we use whatever tests we have very carefully is that South Africa has really focused on what we call hotspots. And these are areas where we have concentrated numbers of confirmed cases, of contacts, and so we've clustered those areas and which we call hotspots. And so the tests that are being done are in and around those hotspots. And then stage 6, which is at the top there, says medical care. We continue to expand the capacity of the health system to cope with the increased numbers that we are seeing now. So we are looking at converting, well, not looking at, already doing it, converting sports fields and other huge venues into hospitals, expanding ICU beds, ventilators and all required equipment. And then we get to stage 7, is really a very, very sad stage. And that's what we have seen in the US, in Italy, in Spain, in China, is the aftermath of this pandemic. And so, but as a country, also to prepare to expand burial capacity and regulations on funerals, and of course also manage psychological and social impact that this pandemic will have. So those are the stages, and as I've said, you know, it's kind of a continuum. The one stage continues into the next, but there's certain components that, of course, highlighted and focused on more. Throughout all of these stages, the importance of surveillance and real-time data has received increasing attention to guide us again, you know, to where we should focus our energy and our resources. Next slide, please. So Mark made reference to this in his presentation as well. During the initial period of the pandemic, much attention was directed at measures to contain the epidemic. What followed was the acknowledgement of the impact of these measures on poor communities. And this picture shows, you know, the conditions under which some of these communities are living. And here we, of course, have a large percentage of the communities who have small businesses, informal markets, spaza shops, and also a high number of homeless people living on the streets. Another reality, of course, and especially in the context of isolation, is the high density of the houses in informal settlements and townships, where people don't only live on top of each other, but where households often consist of large numbers of extended families living under one roof, often sharing the toilets and the taps. And so in South Africa, we have seen pushback of the vulnerable communities to lockdown measures, which doesn't come as a surprise given this context. And one of the things that occurred to me was never before have inequalities been highlighted to this extent as it has with this pandemic. Next slide, please. So this shows the kind of livelihoods that I referred to earlier. And many of these communities, of course, survive on little money. They make money on a daily basis. So instead of protecting themselves from a threat, which in their world may only be seen in abstract terms, to these communities having to stay indoors and depriving them of what they regard as essential in order to put food on the table. Next slide, please. And so again, I think across Africa and countries with similar conditions, there are many lessons that we can learn of what has worked in these environments. And as Africa, we of course need to take into account the context of our countries and how we can best contain the spread and reduce the devastating impact of the high burden of COVID in communities already challenged by these socioeconomic circumstances. Next slide, please. And so in closing, just to summarize, what we have seen is that every country in Southern Africa with reported COVID cases has taken certain restrictive measures to curb the spread of the pandemic. South Africa also has a unique epidemic trajectory attributable to early action, including lockdown, hotspot identification, extensive screening, testing, and targeted community-level intervention. And going forward, from all the lessons that we have learned, what's become apparent is we need to stay ahead of the spread of the COVID-19 at all costs and not wait for patients to come to the hospital. Ongoing house-to-house screening and testing in vulnerable communities is really important. And again, as Wafa mentioned, we have confirmed cases of numbers of confirmed cases, but there may be many more. And the need to continue and intensify surveillance, more so weekly real-time data and contact tracing. And what we need to prepare for in anticipation of an acceleration of transmission. We have seen in the US how field hospitals have been set up for triage, alternate arrangements for decanting hospitals to prepare the staff, especially intensive care and hospital staff that need to be very well prepared. And of course, to be able to secure all the procurement requirements to really implement our mitigation measures. And in closing, test, 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 and test. Thank you.
Thank you very much, Blanche. And I know we're running late, so we're going to extend the time of the Zoom, but I urge both Stefania and Habiba to be as brief as possible in their presentation so we have some time for questions. Please go ahead, Stefania.
Hi, everybody. Good afternoon or good morning. Okay, can I have my first slide? The second one. Okay, so I'm going to talk about Côte d'Ivoire. Côte d'Ivoire is part of West Africa. So Côte d'Ivoire is ranked in the top 10 of African countries impacted by the COVID-19. So we are the 7th country all over Africa. But if you look at West Africa, after Ghana, you have Côte d'Ivoire. Next slide, please. Next. So I'm showing you here a snapshot of the situation in Côte d'Ivoire as of yesterday. So first case was registered March 11, and you see that the progression is constant day by day. Up to now, we have been able to realize 5,000 PCR tests, RT-PCR tests for the diagnosis. 916 cases have been confirmed. 600 are on treatment. 300 have already recovered. And unfortunately, 13 people passed away. Next slide, please. If you look at this map, you see that the high burden in the country is Abidjan, with 94% of the cases reported in Abidjan. The first cases was coming from abroad, Europe and Middle East. Next slide, please. If we look at the sex and age group distribution of cases, you can see that we have also children and adolescents who are impacted. But also, if you look at the distribution between men and women, you see that most men are infected than women, maybe because they have more social contacts. Next slide, please. The Côte d'Ivoire government takes strong action. Our president, our prime minister were strongly involved to take the decision to be able to install measures to try to control the disease. So related to public health, measure has been taken to contain the infection spreading, to prevent this infection spreading with protective personal equipment for healthcare workers, but also treatment algorithms have been designed, and to motivate the healthcare workers, the Ministry of Health give them incentives. Social distancing is very important to fight against this pandemic. So hand washing, mask wearing. Up to now, everybody who is outside in Abidjan should wear a mask. Besides this, security measures are also very important with a curfew and the lockdown of Abidjan. Economical measures are also very important. If you think at what Blanche and Mark just show us, you see that vulnerable population are also in Côte d'Ivoire can be very impacted by the disease. So there is food distribution and there is free bills for electricity and water for them for a 3-month period. Next slide, please. So our Ministry of Health is also in front of the action. So they have a website where you can go on a daily basis and have the correct information. What they have already done is to set up referral center to identify the priority facilities who are able to receive the patient. They have also installed quarantine sites, and something very important, increase laboratory capacities using Pasteur Institute, RetroC, and CEDRES infrastructure. Also to train people in this context where people cannot be in meetings, they use Zoom or Echo platform to train healthcare workers. what is ongoing right now is to set up voluntary screening sites in Abidjan and in country. And also they are building prefabricated system to receive patients for care and treatment. Next slide, please. Partner involvement are very important in our context. So WHO is the coordinating body and for all the partners. And they also deal with the surveillance, and with the Ministry of Health, they issue the situation report now on a daily basis. The US government also, for example, through CDC and USAID propose assistance. And we have also the support of the Africa CDC. Next slide, please. Next, please. So to conclude, in March, upon mathematical model, an estimation was done, and Côte d'Ivoire should reach, based on this model coming from the London School of Health, of Hygiene and Tropical Medicine. The estimation was that Côte d'Ivoire should reach the first 1,000 cases by April 15, but we have not yet reached that. And what they were expecting also, or estimated also, that at the first week of May, we should have reached 10,000 cases. We really hope that with all the measures which have been taken by the government of Côte d'Ivoire with local and international partners, we will be aimed to flatten the peak of this epidemic and allow the health system to absorb the increased number of patients. What we think also is that this situation could be looked at. This situation could be looked at a durable experience for the next sanitary crisis, because for sure our continent will face other crises. But we hope that what we are going through now will help us to be prepared for next. Thank you.
Thank you very much, Stefania. And we move next to Dr. Habiba. Welcome.
Thank you very much. I will present first the first slide, please. Do you have, okay. Just I would like to say some words about the forces and opportunity of the health system to control COVID-19. We have three departments that are involved in this strategy. The first one is the Strategic Center for Health Operation, shock room. It was implemented in 2009 during the H1N1 epidemic. No, before, please. Please come back to the first one. No. There. We have also the Department of Primary Health Care with many rich network. Also, we have National Observatory of New and Emerging Disease. All these institutions are coordinate their intervention to prepare the plan to control a large-scale crisis, natural or provoked crisis. Second one, please. The response to the threat and large-scale crisis are the objective are to ensure the real-time collection of health alerts, to ensure the exchange of information and coordination with other departments with managing crisis, provide communication tools, provide tools from monitoring, and to the surveillance, the event-based surveillance. They have also a tool for exchange information by weekly bulletin, and also, please one. The next, please. The Tunisian response to COVID, the first news letter edit was edited on January 22 to start the strategy of to control the epidemic. Next slide, please. The objective of this response is to curb the spread of the epidemic within the population in order to minimize the potential health impact and reduce infection, illness, and death. Second slide, please. What were and what are the planning principles of this Tunisian response? Tunisia built a strong leadership and coordination of the response, activation of the response and resilience plan for disease with epidemic potential, dynamic risk assessment of potential health and other impacts using the best available scientific advice and evidence to inform decision making. Tunisia worked also and is working with the WHO, the African CDC Center, and the Chinese CDC Center. The most important strategy was the early warning and response system, the 5 early. Second slide, please. Second, next. The early warning and response system that was implemented early during the month of March is early case detection, early declaration, early detection and especially contact tracing, isolation of patient, and early treatment. Next, please. The measures were isolation of all positive cases, quarantine of subject at risk, and containment measures. Second, please. There is the transmission type during the time. The first stage was the imported case. It started from February 28 to March 9. All cases being reported have been occurred, or they came from outside, especially the first one came from Italy. The intervention declaration, case isolation, contact tracing, voluntary quarantine at home, and borders control. The second stage was the local transmission. It starts on March 10 and to April 14. The source of infection is within the country, and the interventions. Tunisia, I think that Tunisia started the intervention for the third stage during the second stage. So we have voluntary home quarantine, social distancing, closure of school and universities, curfew from March 17, and general containment from March 22. Now we are at the community transmission. I think since April 14, we have large outbreaks at local transmission, large number of cases from Sentinel lab, and some hotspots. Tunisia adopted the same intervention that were adopted during the second stage, and they added the mandatory isolation. Next, please. So what is the situation now? We almost, the screening, many people think that we did not test enough in Tunisia. So we, PCR was tested amongst almost 18,000 persons. The total cases until now we have I say, please come back to the net, please. So we have 179 cases. It's about 7 per 100,000 people. Sex ratio is 1, so we have the same number among women and men. We have also many cases among health workers, and we have not a lot of deaths. We have just 37 deaths. The case fatality is very low, and the mortality ratio also. Next, please. This is the trend of the epidemic. So we have the histogram, the number of cases per day, and the line is the cumulative number. So the big variation. So we have, sometimes we have a lot of people screened and that are positive, and after we have less people, we think that it was the problem with the screening. So we are sure that the number of the real number is more than we detected. Next, please. So when we started, the first case was detected in March 2. It was in the southwest city, Gafsa, near Algeria. And now we have all the governorate have detected some cases. We have some hotspots. The red one are the hotspots, so Tunis, the capital, Sousse, the southeast, and also the southwest. We have the number incidence rate per 100,000 people. So the problem is the spread is very some cities. Spread was very rare in some cities. Next, please. What are the challenges? The first challenge is the screening strategy. How to enhance and scale of screening. Is it should we as the contact, or to have more or mass screening? This is the debate in Tunisia. Also, how to integrate and involve primary healthcare in this the screening and the contact tracing. This is also, there is a discussion about this. How to prepare the medical care, especially for the intensive care unit. We have almost 500 between public and private sector. is it enough or not? Also, this is a discussion. We have a discussion about this. The crucial issue now is how to improve the healthcare for general population, especially NCDs, maternal and child health, mental health, emergency, because since the epidemic, people do not seek care, especially for NCDs, and we think that we will have a negative impact for this population. So we are preparing and we are thinking how to restart the care for this group of population. It's not easy because we have to organize all the hospitals, primary health care, to have two pathways, one for provides positive and one for provides negative. And we have also to protect the population, the health worker, and also to inform them. I think that we have to inform and to protect health workers and to respond to their psychological needs. We have also another challenge is how to prepare the country for the after containment, the management of the work spaces, how to, are we prepared for this? We are thinking about this, and we have, it's multi-sectorial approach, and all the sectors need to be involved in this project. Next, please. There is also a huge issue with the economical and social challenges. I think that Tunisia is like many of countries in Africa, but also elsewhere. Tunisia is facing the deepest recession since its independence in 1956. We have macroeconomic imbalances and a very high external, as well, public debt. We how to contain the spread of the virus, mitigate the human, social, and economic needs amid an unprecedented vulnerability, and to ensure the sustainability of the external debt. These measures involve raising health spending, strengthening social safety, and supporting small and medium hit by the crisis and the employment. So, beside the health issues, there is economical and social challenge, and it will be very difficult for Tunisia to resolve all this problem. Next, please. Thank you very much. Thank you.
Thank you very much, Dr. Habiba, and thanks to all the speakers. I know we've gone way over time, and we will be posting this webinar on the ICAP website, as well as the Global Center website for you to share with others as well. Unfortunately, we don't have any time for questions today, but we have received several questions, and those questions will be answered. Also, we'll post the answers to these questions shortly. So I want to thank everyone for your participation today, and particularly for your interest in this very important topic in terms of what is going on now in the African continent, as well as also thinking about the measures that have been put in place, as well as the concerns about what's going to happen next in terms of the trajectory of this pandemic, and the importance of the global community at this point in time in making a commitment, a deep commitment to try to support the work that's going on in Africa, as demonstrated by all the speakers today, and to stand by these countries during this very difficult time. So thank you very much, everyone. Particularly, I want to thank the Global Centers in Tunis and in Kenya for co-sponsoring this webinar, and thank all of our speakers today, and thank all of our audience for joining us today on this webinar. Have a good day, and take care.